Let's move forward to our second case discussion and presentation, and evolution of upfront therapy for transplant-ineligible patients. And so please welcome Shaji Kumar.
Good afternoon, everyone, and I would like to thank Brian for the opportunity to be here at the symposium today. One thing you might notice, always you see the transplant-eligible talk before the transplant-non-eligible talk. So this is not by purpose, but I think increasingly, it makes sense in the sense there's increasing convergence as to how we are treating patients with myeloma, irrespective of their transplant status. It's in no means a reflection of transplant being any less important in this disease. What I'm going to try and do over the next 10 minutes is to kind of walk you through how the treatment has evolved for patients who are considered ineligible for stem cell transplant, who don't want to go to a stem cell transplant. Before that, let us go through the patient case first, and these are my disclosures. So now we have a 75-year-old male who presents with increasing back pain, and that was associated with radiculopathy. MRI or imaging studies shows multiple lytic lesions, clearly myeloma. Initial lab evaluation shows elevated total protein, slightly elevated creatinine, has a slightly decreased hemoglobin, normal calcium, and M spike of 3.2 gram per deciliter, G kappa, elevated kappa-free light chain, and elevated beta-2 microglobulin, placing this patient at ISS stage 3, 60% plasma cells in the bone marrow with a FISH showing trisomies of 7, 11, 14. And with normal conventional cytogenetics. So which of the following therapies would be used for this patient as the initial treatment? Please go ahead and vote.
Want me to walk over there? Want me to walk and tell them?
Yeah, you could.
Okay. I'm just going to go tell them there's a mic off on in the audience.
Okay.
All right. So we have about a third of the group going for bortezomib, lenalidomide, dexamethasone, and we have about 1/5 going for daratumumab, lenalidomide, dexamethasone.
Over there is on.
All right.
You can hear him talking.
That's a good place to start off with.
Yes.
Let's move on to the, see if I can move past this slide here. Yeah, here are the recommendations from the group up here. As you can see here, looks like those two choices are reflected very well in this panel here. Now, so let's walk through why we have chosen, or the majority of us have chosen, the combinations that have been highlighted here. I think it's important to think about, again, what is the goal of treatment in patients with myeloma? Obviously, what we want to do is to try and get the tumor burden to the lowest possible level. And what has been important, obviously, is the diagnosis. And as we just talked about, the subtleties in terms of differences between who has smoldering myeloma that does not need therapy and active myeloma that needs treatment. And equally important is the risk stratification in patients with myeloma. We are not going to go much into the risk stratification at this point, but I just want to walk you through the overview of how we treat patients with myeloma. One of the questions that we have always asked is this patient eligible to go to a stem cell transplant, in which case these patients then get a limited duration of induction therapy, followed by a consolidation that is typically an autologous stem cell transplant, followed by maintenance therapy. And Dr. Morrow is going to walk you through the current approach for these patients. What I'm going to try and focus on are the patients who are considered to be transplant ineligible, where the typical approach is to start with a therapy and follow the same treatment for a period of time. But the important question is, who are these patients whom we call as transplant ineligible? And there are very different ways of defining it. Beauty lies in the eye of the beholder. But the primary question has always been age. And a lot of the randomized trials have been designed based on the age of the patients, and often the magic number has been 65. And there's no good rhyme or reason why it's not 60 or why it's not 70. But 65 is what has been used in the phase 3 trials. But we know from a variety of different studies that even older patients can go to stem cell transplant. There is an analysis from the CIBMTR that's going to be a poster at this, or a presentation at this meeting that I would encourage you to attend. There are other factors that are also important, things like the comorbidities, are they able to undergo the stem cell transplant? Frailty is important. Access to healthcare often plays a role in who gets a transplant and who does not. And increasingly that you realize that patients walk into your office already having made up their mind whether they're going to have a transplant or not. So that the patient choice is important in making that decision. And the other thing that is changed over the past, especially over the past decade, as the type of treatments we use for newly diagnosed myeloma converges, the question of who is eligible for a stem cell transplant doesn't need to be made the moment they walk into the office. That's probably the last thing they want to hear from you. On top of everything is stem cell transplant. So we can easily ask that question after one cycle of treatment when they are feeling much better and some of the complications of the disease have been reversed with the initial treatment. Then the next question is, why is age an important factor in terms of deciding the course of therapy? The most important thing I think is comorbidities, because many of these patients have other comorbidities like hypertension, diabetes, which can be made worse by the treatments that we use in this disease. Renal insufficiency is common, leading us to having to dose modify, osteoporosis, which is not going to get better with dexamethasone, and the psychological issues, which certainly won't get better with dexamethasone. And there's obviously the frailty that is increasingly recognized as important, and we are trying to figure out how best can we assess it in a very simplistic fashion because it does have an impact on the treatment. Altered drug metabolism, limited social support and financial issues, and limited mobility and independence all play a role for these older patients. So let's take a look at where we started off from and see how this has evolved. So when we go back 20 years ago, the median overall survival for patients with myeloma, as you can see, is about 2.5 years with melphalan prednisone or comparable regimens. And we have tried over the years to ask 3 important questions. One, can we make melphalan prednisone better? Can we actually get rid of melphalan, or do we need it? And finally, how long should we treat these older patients with myeloma? So in order to answer the first question, there have been a series of phase 3 trials that have been done that have initially tried adding thalidomide to melphalan and prednisone. Some of them showed PFS improvement, a couple of them with overall survival improvement. We have tried adding bortezomib to melphalan and prednisone. The VISTA trial showed that adding bortezomib definitely improves the overall survival in these patients, with all different subgroups of patients deriving benefit. But I think where we are today is, how can we incorporate even the newer agents into this paradigm? So all of you are familiar with the trial results from Alcyon, which compared daratumumab with VMP versus VMP, and demonstrated that these patients have a much better progression-free survival by addition of daratumumab to the VMP regimen. And the response depth was much better when you added daratumumab to bortezomib, melphalan, prednisone, showing that this is an effective combination. And in this meeting, you will also hear from Dr. Mateos the updated results showing that there is an overall survival improvement for addition of daratumumab to bortezomib, melphalan, prednisone. So clearly, this is a regimen that's already been approved in different parts of the world, and certainly something that you can use. And many of you in the audience probably have used this. But the important question for us is, now that patients with myeloma are living 10 plus years, do we really need to use an alkylating agent like melphalan right in the beginning with some potential consequences in the long run, both in terms of bone marrow reserve as well as second malignancies? So there have been an increasing push to see, can we develop regimens that are melphalan free? One of the original trials, the first trial looked at using lenalidomide dexamethasone either for 18 months or continuously, and compared that to melphalan, prednisone, and thalidomide, and showed that Lendex used continuously had a better PFS and had a better overall survival compared to melphalan, prednisone, thalidomide combination, initially showing that Lendex is a reasonable approach for these patients. Subsequently, Dr. Dury did a phase 3 trial in SWOG that looked at the combination of bortezomib, lenalidomide, dexamethasone, comparing that to Lendex, again showing that there's not only a PFS improvement, but actually an overall survival improvement, suggesting that we don't necessarily need to limit ourselves to a doublet. We can actually use a triplet even in these older patients. But we all know who treat myeloma patients that it can be challenging at times to give them the standard VRD regimen. And there's this VRD light regimen that was developed by the folks at MGH, which looked at a more lighter version of RVD, which again gave a very comparable response rate and depth of response, suggesting that, again, we can use these same 3 drugs, but with some modifications. And more recently, there's data from the MAIA trial that looked at daratumumab combined with lenalidomide dexamethasone. This essentially randomized patients to continuous therapy with either the doublet or triplet. And this trial clearly showed that there was a significant improvement in the progression-free survival compared to just using the doublet with the use of daratumumab. And this, again, correlated with a very deep response, including the MRD negativity rate in these patients. So clearly, we have data showing that there are 2 triplets that have shown benefit in this patient subgroup. There will be updated data from the MAIA trial that will also be presented at this meeting. Now, the next question is, how long should patients remain on treatment? Many of these phase 3 trials continued therapy until progression, and we don't have a very good answer yet. But this is a meta-analysis that was done by Dr. Palumbo based on a bunch of different European trials, suggesting that maybe continuous therapy did improve the overall survival compared to a fixed duration therapy. But I would say that the answer is still unknown, and there is a phase 3 trial in ECOG where we randomized non-transplant patients to 2 years of LEN maintenance versus continued till progression LEN maintenance. And hopefully that trial will give us some answer to that particular question. But what is very clear is that the shorter duration of dexamethasone is better. There is this trial that was phase 3 trial that was presented by the Italian group at the last ASH meeting, where they reduced the dose of lenalidomide and discontinued the dex in a planned fashion after 9 cycles of therapy, and in showing that less is better. And the patients who actually had the dex dropped and the lenalidomide dose dropped actually did much better in terms of event-free survival. So I think there's still an ongoing debate about the duration of therapy. It certainly improves PFS, but I think there's mixed effect on the overall survival. There's obviously the question of increased toxicity, both financial as well as other side effects of the drug, and the quality of life. So I want to conclude by saying that in 2020, we don't necessarily need a melphalan-based combination for the initial therapy of patients with myeloma, even those who are not considered eligible for stem cell transplant. I think that the 2 triplets, I think, which should be the standard of care for today would be bortezomib lenalidomide dexamethasone or daratumumab lenalidomide dexamethasone, and then there's increasingly the adoption of the dara lendex into this practice. However, until we have more mature data from the dara combinations, I still would prefer to use a proteasome inhibitor-based combination in patients with cytogenetic high risk. And in those patients who are really much older and frail, the doublet still has value, and again reinforced by the control arm in the MAIA trial, again showing a 32-month PFS for the lendex regimen. And I think for right now, we can continue the treatment till progression to the extent it's tolerated until we have more definitive data from phase 3 trials. But I think it's most important for these older patients to start low and then go up on the doses as tolerated, rather than trying to treat them with the full dose of all the medications. And I think one thing is very important is to discontinue the dexamethasone as soon as you can, and very carefully monitor these patients for toxicity related to therapy. So I'll stop there, and thank you for attention. And I guess we'll go back to our patient case here. Let's see if we have changed anyone's mind. Yes. This is again the patient case example. We have the 75-year-old gentleman with ISS stage 3 disease. Let's see what we're going to use for treating this patient. There's some soothing music here. So. All right. We've gotten the choices narrowed here, so to 2 regimens. So 82% of you will use either one of the 2. All right, we converted all the doublet treaters to triplets. Thank you.
All right. So thank you for that. So far, VRD is winning the day, I think. It's actually interesting to ask Shaji, you made one point, which was that you recommended VRD for the high-risk patients versus DRD, and certainly there are data to indicate that would be a good choice. How about KRD for an elderly patient? Do you want to comment on that?
Certainly, I think for the high-risk patients, in the transplant-eligible patient population, especially, I think if you look at the MSMART algorithm, we have recommended using KRD combination for the high-risk patients. The basic assumption there is in patients with high-risk disease, the existing therapies haven't really improved their outcomes. So can we hazard a guess from phase 2 trial data that a particular regimen may be better than what we use today and potentially use them with the question of risk versus benefit? And obviously, what we really need is phase 3 trial data, and we will get that from the ECOG trial that looked at the KRD versus VRD, which hopefully we will hear soon. But in the older patient population, I am a bit more uncomfortable taking that leap of faith because there is definitely the toxicity aspect which might be more difficult for the older patients to handle. So I think in the older patients, I feel safer using something where we have lots more data, both in terms of the VRD or the VRD light and the outcomes that have already been shown in those patients. So I'm willing to hazard, less willing to hazard a guess in the older patients and the younger patients.
Okay. Raise your hand if you have a question, and a microphone will be brought to you, okay? Philippe needs to say something first, and then we'll take our first question in the middle here, I think. So, Philippe, you want to go ahead first?
Yes, in the meantime, this case was not that simple, to my opinion. 75 years of age, and Shaji did not mention anything regarding performance status and regarding comorbidities. So that's very difficult for me to propose VRD without knowing anything regarding frailty, comorbidities, and so on. We know that potentially VRD may be toxic in a frail patient, and you mentioned very clearly this in your talk, Shaji, thank you for this. And so I was unsure, so that's why my choice was Lendex bracket bortezomib, because Lendex is very feasible for this elderly patient with some comorbidities or frail patients. Dara-Lendex, more than 20% of the audience wanted to use Dara-Lendex. This is not yet approved in Europe, at least. We cannot use Dara-Lendex yet. And we know that this combination is potentially very interesting, very safe. And into Maya, more than 40% of the patients were above 75. So potentially a good option, but for the future, not yet available in many, many countries. So I'm really surprised. What we want to use or what we can use is always very different.
Okay, so we'll take a question. Number one here, I guess, in the middle. Please go ahead.
Thank you. In my opinion, we have two parts of the treatment of patients with multiple myeloma. The initial part, where the goal is to kill as many myeloma cells as possible, as fast as possible. And the following part of the treatment is to reprogram, the goal is to reprogram the patient's immune system so we can obtain control, long-term control of the disease. And this has important implications for how we look at the response, the speed of the response, because in the initial part, we want a rapid drop of the M protein as a sign of effective killing of the myeloma cells. And in the later part of the treatment, we can be completely satisfied if the M protein is dropping slowly, even over a year or more, coming down, because this is a different part of the treatment.
Right, so those are two options. Actually, Vincent is the one who has focused on these two strategies to slowly control versus decisive therapy. You want to comment on that?
No, that's very eloquently stated. I don't want to add anything because you just put it down very, very clearly.
Thank you. Yeah. Okay.
Questions?
So while waiting for that, okay, great.
I have another one.
All right. Yeah, please go ahead.
In your practice, what was the most long time that you use dexamethasone in elderly, fragile patients?
So I try to take off the dexamethasone as soon as I can. Once I start seeing the patients responding, I progressively dose reduce them, and once they get a get to a deeper response. Usually by anywhere between 6 to 8 months, I try to completely discontinue the dexamethasone. The older the patient, the sooner, and sooner I see the response, the sooner I try to take them off.
Okay.
Number two?
If age is really just a proxy for comorbidities, and we can assess comorbidities, why even look at age?
So it's not only comorbidities,
Okay.
right? I think there's obviously other things that go with that. So there's two parts to it. One is what you assess at the time of diagnosis in terms of comorbidities. And the second thing we all see in the practice is you can have a 75 and a 65-year-old, you give the same therapy. The 75-year-old is certainly going to have more toxicity. So I think the question is not what they can take today, but what they can tolerate until tomorrow. So I think that also needs to be taken into account. I think that's one of the reasons why I think it's, some people look very good, a 75-year-old, but you can make them look very bad by giving something that is intense. So I think we really need to factor that in as well.
Maybe I can ask the panel, do we have any sense that the biology of the myeloma is different by age, that it has a different pattern of response to therapy, that we should be looking at that?
Well, I think in terms of the high-risk group, so the older you get, actually, the lower the incidence of the high-risk disease. So that's actually a better thing.
Yeah.
I do think there's still the worry about high-risk disease in elderly that you still need to give them a proteasome inhibitor. But thankfully, it's on the lower side. And I would agree with what was said earlier about looking at long-term immune function. And it probably is lenalidomide and potentially a CD38 antibody that enhances that immune effect over the long period of time.
Okay. Other questions?
Any other questions? Okay.
Any
other comments?
I think I just wanted to highlight again what Philippe said about the performance status. I think, we all talk about adapting therapy, but it's remember that these frailty assessments and the comorbidity assessments are a dynamic thing. They change. So just because the patient was considered frail when you saw them first and put them on a doublet, and if they come back at the end of the first cycle feeling a lot better, please do consider changing that into a triplet.
Yeah, Vincent, yeah?
Well, I think one thing that didn't come up, and I think it's important to consider, is that clearly we have two triplet regimens that are really good for early control of myeloma. That is bortezomib Lendex and daratumumab Lendex. But one is far more expensive. So I think cost absolutely has to be considered when you're making the call in terms of what is the best regimen for your patient. Please talk to your patients about affordability and choose a regimen that you think would be something that they can afford. There is no point in prescribing a regimen that is not affordable. And the second thing to keep in mind is you cannot compare one trial versus the other, so you cannot compare the SWOG trial to the MAIA trial. The SWOG trial used a triplet for 9 months, and then after that it was just lenalidomide dex. Whereas if you choose daratumumab Lendex and you want to use it like the MAIA trial, then you're talking 4 or 5 years of a triplet and 4 or 5 years of that extra cost. So keep those two things in mind. It's not just as simple as just, one can be mixed up with the other.
Yeah, really important practical points there.